All right, everybody. We got to do this one virtually, and I'm going to try and make it as painless as possible. But we got to talk chapter 12, which is disordered eating and exercise patterns in athletes. And I hope you're watching this, and you'll want to make sure you watch all the way to the end, just because I'm telling you now, right here in the first few seconds of what we're doing, that I will have an assignment hidden in this particular presentation somewhere. So make sure you at least keep an ear out and take some notes, and this will help you guys. So here we go. We're going to start with a little bit of story time. So we're going to do this case study here about Karen. Listen up. You don't have to read along, although I included it here. But here's Karen's story. Karen had been running ever since she could remember, but it was not until her first year in high school when she joined the cross-country team that she realized that she was in love with running. She loved everything about it. The digital training watch that she got for her 13th birthday, the wind in her long hair, the quiet time she had to herself away from her family's problems, and the feeling of accomplishment when she finished a race. She made a name for herself the first year, and she realized that she could be the best runner at her school if she just applied herself. By her junior year, she was featured in her hometown newspaper as someone to watch. She adopted a semi-vegetarian diet and altered her running stride to make it more efficient. She came in second in the regional meet and earned the right to go to the state championships. There, she had a strong start, but faltered down the stretch, and she was disappointed for herself and her family. Her coach told her that if she trained just a little harder, that she could be a contender in her senior year. Her parents were excited about the prospects of her earning a college athletic scholarship. Without some financial help, they had little hope of sending Karen to college. After the state meet, Karen immediately began to train and to pay more attention to her diet. She noticed that the winners at the state meet had brought coolers with their own food and drinks. She became a vegetarian in earnest and began to eat differently than her friends and family, which meant that she often prepared her own food and ate alone. Eating alone turned out to be advantageous, as she could avoid the family mealtime discussions that always left her feeling as if she was not good enough in her parents' eyes. Her best friend in middle school told her that she was no longer the happy-go-lucky girl she once was. Karen took that as a compliment. She was maturing and focusing on the future, college, running, and maybe the Olympics. She had dreams, and they involved taking her beyond the little town in which she grew up. She was diligent about her training and diet, and her senior year was all that she had hoped. She smashed school records, erased regional marks, blew by the competition, and won state meet by a record margin. Sought after by many colleges, Karen traveled out of state on recruiting visits. She received offers of athletic scholarships from several schools that were impressed with her perfect high school grades and high scores on her college entrance exams. Karen chose to attend a top-notch school on the other side of the country, even though her parents had reservations about her being so far away and were concerned about how they would pay for the costs not covered by the scholarship. Her freshman year at college was an eye-opener. Her college coach was much more demanding than her high school coach, and everything about her seemed to be under scrutiny. She had only made a few friends, acquaintances really, and she missed her family, although her coach was like having family close. Much of the dorm food was not vegetarian, and she found herself with few choices and even fewer foods that she enjoyed eating. One of her goals was to have the highest GPA on the team, but attaining perfect grades in college was much harder than in high school. When she was not training, she was studying. Karen was surprised to find out that the athletic scholarship she thought was guaranteed had to be renewed each year based upon her running and academic performances, something that really upset her parents. Although her coach never said it directly, he intimated that she would perform better if she were leaner. A couple of her teammates, whom she noticed were thin, wondered aloud if she had what it took to make it as a college runner at an NCAA Division I school. That was all the motivation that she needed to develop a stricter training program and, for the first time in her life, a diet to lose weight and become thinner. As she stepped up her training and restricted her diet, her performance began to improve. Karen redirected herself to running and was almost robotic in her approach. She had convinced her parents to let her move into a single room in the dorm and not buy the meal plan. They reasoned that her diet would be healthier and that she would be happier if she prepared her own food in the small kitchen at the end of the hall. Karen found that she loved creating meal plans and looked through vegetarian cookbooks. She made tremendous improvements by the end of her sophomore year, and her coach said that she was poised to have a breakout junior year. Unfortunately, She developed a painful stress fracture in her lower leg early in the preseason of her 3rd year. Karen struggled for many months, not only because she was unable to train, but also because she needed the intense physical activity to keep her weight low. Her coach was not paying much attention to her now that she was sidelined with an injury, and she was already worried that her full athletic scholarship might be reduced for her senior year. Karen gained 10 pounds in 2 months while recovering from her injury, which scared her, so she began to restrict her diet to a few healthy foods, salads, bagels, fruit, and water, and weigh herself daily. She even cut her long hair in an effort to feel lighter. By the beginning of the season, she had received clearance to restart her training, but her injury had substantially set her training back, and she was concerned that she was entering racing season without the necessary preseason training. Karen now relished her training runs and began to run on designated rest days, although she knew that if her coach was aware of this, he would never have allowed it. If she had been honest with herself, she would have realized that she did not so much love running anymore, rather, she needed running. Her coach had mentioned that he was worried about her apparent lack of eating, and she took his comment as a good sign, since he obviously was paying attention to her again. Karen assumed that she was eating more now than she was training. She made sure that she was not lying by increasing the size of her salads. Secretly, she was a bit worried because her menstrual periods, which had been light but regular since high school, were now almost non-existent. Just 2 periods in the last year. She had not dated anyone since coming to college, so she was not worried about being pregnant, but she did have an immediate health concern: recurrent upper respiratory tract infections that had plagued her for months. Her junior season started with an excellent showing at a big meet, and her coach repeated his prediction that this would be her breakout year. Her next effort was hampered by a cold, and her coach seemed sympathetic to her frequent infections, although he did ask her specifically about her training and diet. 2 more meets featured mediocre performances, and she was not chosen to travel to an out-of-state invitation-only event. She resolved to work harder, training more than usual and eating a little less than she had been for the past few months. At the next meet, she fainted at the start line, and her coach said they needed to talk. She believed that she just had a bad day and that everything would be fine for the next meet. He believed that she had Anorexia Athletica and needed immediate treatment. So that's a case study. That's something that I'm going to ask you a few questions on for a lab that I've got later in this presentation. So you'll want to go through it again. You'll want to listen back to it because the answers are in there. But it shows you that someone can go from being perfectly normal and healthy to a pattern of disordered eating all the way into a full-blown eating disorder. And that kind of is a story that sums up how that progression works from one end of the spectrum to the others. And that's what we're going to be talking about today. Inappropriate eating, dieting behaviors, training demands, and psychological stresses, and how they all work together to lead to these mental disorders that actually affect us nutritionally and physically when it comes to performance. So a couple things about food, right? Normal eating is flexible, needs to be moderate, balanced, and varied. And it does involve some constraint, and that's important in order to maintain some control, but it should not be an overly strict discipline. Now, an athlete's diet might be more constrained and less flexible because of the training, but it should not be an obsession. And if it is, well, then that can lead us to some of the things we're talking about here. So there you see an overview of eating and exercise patterns, right? All the way over on the right smack in the middle in that neutral area, a little bit off to the right, you've got your normal eating, right? A little bit of restraint, flexibility within a defined eating pattern, no psychological pathology. Overeating can be problematic too, so that's over on the far end of the right side. And then you've got disordered eating towards the left, which gets into mild to moderate psychological pathology, eating and hunger not being aligned, all the way down on the far left to full-blown eating disorders, which we're going to talk all about today. Now, disordered eating, once again, is not the same as an eating disorder. Disordered eating is merely a deviation from normal eating, but it's not a fully defined clinical eating disorder. So therefore, because it's not in the diagnostic realm of actually getting classified, it's therefore not easily defined or recognized. It's going to go unrecognized for quite some time. You have to consider eating within a larger context. So things like inability to eat when you're hungry or to stop when you're full. establishing a rigid eating pattern, overemphasis on food and overemphasis on weight, overly restraining the intake of certain foods. These are all specific situations that can lead you to think that there might be something wrong. Let's talk about the one that is probably the most explored, one of the most well-known, and that is, of course, anorexia nervosa. It is a full-blown psychiatric condition. And one of the things about it in terms of its characteristics is it is a refusal to maintain a minimum body weight. And really, quite simply, that means that there is no such thing as being too thin. It's never like, oh, I just want to lose 5 pounds. No, it is a continuous downward spiral of trying to be lighter and lighter and skinnier. A complete refusal to maintain a minimum body weight. There's no maintenance. It's just more lose, lose, lose. There's an intense fear of weight gain in this psychiatric condition, and it's all because of an extremely distorted body image. Okay? That means that they don't see themselves the way the rest of the world does. You know, to us, they might appear very visibly thin, or if they're on their way down this really dangerous path, they might look relatively healthy or just a little on the thin side. But to them, in their mind, in their warped view of themselves, they are not able to recognize that. In fact, they just see things as being too fat, and I can lose more here, I can lose more there. So they just continue in this behavioral pattern to just lose, lose, lose. And therefore, that's what kind of makes it a psychiatric condition. Their perception of what they see doesn't really line up with the reality of what's happening. 2 subtypes of anorexia nervosa. The restricting type, which is the more common, and it's the one that we see more of. And there is a binge eating purging type that is not to be confused with bulimia nervosa, which we will talk about, but it's a lesser known subtype. As for the prevalence, who does it happen to and how frequently? About 0.5% to 1% of late adolescents and early adult female population. So that's your age range. You know, late teens, early 20s. Male prevalence is unknown. It's very rare that you hear or see any male examples. The only one that I know of personally is not an athlete, but a guy who is the lead singer of the band Silverchair. He actually is known to have had anorexia nervosa. He's had some other issues as well. I looked it up not too long ago, but he wrote a song that was a pretty major hit. I remember the video on MTV. When I was much younger, called Anna's Song, A-N-A''S, Anna's Song from Silverchair, that was about his struggles with anorexia nervosa. So that's a well-known example, but it's one of the only ones as far as I know. So very, very minuscule portion. It's primarily something that happens in females. There you see the common age range. Usually high school and college are the critical times when these things kind of take off. Now, in order to be diagnosed with this, to be diagnosed as having this very specific disorder, you need to meet certain diagnostic criteria for that. And that would be that refusal to maintain a minimum body weight, intense fear of weight gain, that disturbance in view of body weight or shape, and then, of course, amenorrhea, which is the cessation of the menstrual period. So those are all things that a doctor is going to look for in order to officially classify someone as having anorexia nervosa. And there you see a person, a young lady who is very clearly suffering from anorexia nervosa. So there's a visual representation there of what this looks like. Bulimia nervosa. It is very different than what we were just talking about in anorexia. Another psychiatric condition, and that has recurring binge eating as part of its pathology. And there are 2 subtypes. There's the purging type and the non-purging type. But again, with non-purging, we'll get into binge eating disorder, which is its own diagnostically sound psychiatric condition. Anyway, let's talk purging. Let's get a couple stats out first. 1 to 3% of late adolescent and early adult female population. So again, late teens, young adulthood, Prevalence in males is unknown. It is not something that is typically an issue that plagues males, but that adolescence to middle adulthood is where you'll see it, and primarily in women. So how do we diagnose this one? Again, you can't get diagnosed unless these things are going on. There are recurring episodes of binge eating. They're just taking in a ton of food all at once. And then recurring inappropriate compensatory behavior. So you are compensating for that binge eating. And what we mean by that is you're purging it somehow. You are compensating by taking in so many calories and so much food. Well, now you have to get all of it out somehow, some way. And we'll talk more about those methods in a moment. Other parts of this diagnostic criteria has to happen 2 times a week for at least a period of 3 months before it can be diagnosed. Usually there's an undue influence of body shape or weight on self-evaluation. These episodes are not related to anorexia either. And again, we mentioned the 2 subtypes. One of the interesting things about bulimia, however, is that it is not easy to spot someone with this particular eating disorder. Now, you saw the photo of the young lady who was suffering from anorexia. That is visibly noticeable. That is something that you can pick out and say, hey, something's not right here. When it comes to someone that has this particular psychiatric condition, it's a little bit different. It's not easy to identify and see. We will see how we usually find that, though. The couple of ways that the compensatory behavior happens, or purging of some type. They got 2 listed here, but there is a third, which I'll tell you. There's self-induced vomiting. That's the most common. That's usually 2 fingers right down the throat and vomiting the food back up shortly after it's eaten. In 1/3 of the cases, they might use laxatives. Laxatives used to flush it all out of the other end. So there's that as an option. And then actually another purging method that isn't mentioned here is vigorous, long exercise. Like people, they go to the gym for hours and hours and hours and just burn and burn and burn and burn and burn calories in order to compensate for all that they took in. Now, how does someone get noticed as far as having this particular psychiatric condition? Like I said, it's not something that they visibly present with when it comes to their body shape. But instead, because of some of these behaviors, there are some signs, just you got to know what to look for. Bulimics might have calloused fingers, and you can see that there down at the knuckles below the fingers. You can see the calluses and a little bit of spotting there from the acidic content of the vomit. So just shoving your fingers down your throat, you're getting acid there. That acid is actually going to burn your fingers, and it will present with some significant signs over time that show that something's going on. In addition, because of that acid coming up, being regurgitated from your stomach and coming up through your mouth, and so frequently, that acid also has an effect on your teeth. So dentists are the ones that can usually spot that something might be going on related to bulimia nervosa, because tooth enamel starts to get worn away, and that's a result of that self-induced vomiting. So that's a little bit on how we're able to pick those out and the methods for purging. Binge eating without the purge is known as binge eating disorder. So there's that huge binge and no compensation to get rid of everything that was taken in it. So as a result, you just take in that much food. Well, I mean, you're going to put on weight, and obesity is therefore a result. What is this marked by? Recurrent episodes of binge eating, usually during a discrete period of time. So it's when no one else is around, in a closed off area so no one can see you, and then that person actually goes and eats a remarkably large amount of food, an unusual amount of food, and they all the while they're doing it, they have this feeling as though they cannot control that behavior. And that's an important component when it comes to the diagnostic criteria. You might say, oh yeah, they have control. Remember, these are psychiatric conditions. It's not as simple to say that, oh, they just need more discipline. Their thinking, their behavioral patterns are altered as a result of whatever's going on with them. So that lack of control is an important component of this. So usually you'll see rapid eating until uncomfortably full, eating large amounts when not hungry, eating alone because of embarrassment. You don't want anybody to even see how much you're going to eat. and then feeling disgusted with oneself. There's marked distress after binge eating, so it's not like they don't feel bad about it. They do. That's another part of this. And it occurs on average at least once a week for 3 months. And with those no compensatory behaviors, again, that's just going to lead to more pounds and, well, obesity. There are other specified and unspecified feeding and eating disorders. Again, more psychiatric conditions. Most outpatient eating disorders are going to be EDNOS, which is an acronym meaning eating disorder not otherwise specified. It's a little bit harder to track because it's not well defined. But if someone is suffering from any kind of combination of some of those signs and symptoms that we've talked about for some of these primary eating disorders that have been mentioned thus far, but yet it doesn't quite meet all of the criteria to be diagnosed as one of those three, but yet there's something still very evidently wrong, well, this is where it would get classified under eating disorders not otherwise specified, or EDNOS. Now, this is one that is not included in the DSM, and we say that I probably should have mentioned this before. The DSM-4 is the Diagnostic and Statistical Manual put together by the APA. Yes, that APA, the same one that dictates how you write all of your papers in APA format. But what the APA, or the American Psychological Association, does is, in order for doctors, psychologists, psychiatrists to be able to look at someone and evaluate them properly, they need to know exactly what the conditions are in order to give someone a diagnosis of a particular psychiatric condition. So the DSM-4 is a manual that is published and revised every so often that includes all of the diagnostic criteria in order to diagnose someone with a varying number of psychological disorders within the mental health realm. Okay, so that's same thing like doctors have their reference books, so that's how they know what type of disease someone has, so they can diagnose them. In order to diagnose a mental disorder or a psychiatric condition, the doctor has to consult the DSM-4. So this one, Anorexia Athletica, is not in the DSM-4. But what we see is reduced body weight and loss of body fat, and that's related to athletic performance. So you can see how the tie-in is here, and that's what it has to do with this course more specifically. That loss of body weight results in a lean physique, which again is good for sports and exercise. Weight cycling is usually present. Think about wrestlers, boxers, fighters. Typically different times of the year, different seasons, they cycle in terms of what their weight looks like so that it fluctuates. Usually it is marked by a restriction of food intake and or excessive exercise is voluntary or at the suggestion of a coach or trainer. So yes, even coaches and trainers might suggest some of these behaviors that we are just got done talking about how bad they can be. But the other thing about it is that these issues, while something like anorexia nervosa is something that plagues a person every single day, all the time, and they can't really get out from under the weight of it, this is specific pretty much to the competition period, to training and competition. So when you take the sport away, this problem goes away. So that's one of the things that makes anorexia athletica different than anorexia nervosa. Because it's so odd and it captures actually a wider variety of athletes, because you think any wrestler, anyone in combat sports where they have to make weight is probably going to fall into this category. They have to cut weight. They have to restrict their diet. They have to purge. They have to, in order to cut weight and burn more calories. Those could all be considered under this umbrella. So what's harmful, what is beneficial to actually help you in the sport, it's really a gray area. It's difficult to determine, and the prevalence really isn't known. Wrestlers being some of the best examples. They're going to eat very abnormally during the wrestling season, but when it's not wrestling season and everything's good to go, they're fine. They don't meet the criteria for any of the mentioned eating disorders. Some people are addicted to exercise. Again, this is hard to define and quantify, and the intent of the exercise is an important factor, and this is something also not diagnosed by the DSM, but one of the big things about it to know that it's an actual problem is that there's impaired functioning. And when I say there's impaired functioning I mean this behavioral pattern of actually working out all the time, so much every day for so long, it's actually interrupting and interfering with other parts of their life. So that's one of the things about it. Usually it also is marked by if they cannot work out, they experience signs and symptoms of withdrawal, and there's also the presence of an eating disorder there as well. So the exercise addiction, if you will, is a thing, but it's not easily classified. So how about we've talked about the disorders now? How about what does this look like in athletes? Again, like we've been mentioning, it's tough to study and determine. It might be as low as 1% in female athletes. It could be as high as 62%. Any clinical eating disorder in female athletes. It is one thing we do know for sure is that it is overwhelmingly something that applies to females and not males. And another thing here, which is, I suppose, some encouraging news after hearing all this, is that disordered eating patterns are far more prevalent than an actual full-blown eating disorder. It's also more prevalent in sports where you're supposed to have a lower body weight, which if we were in class discussing this, we'd talk about what they are, but you'll see some examples here shortly. So some potential triggers of how this happens in females, it could be because dieting is something that they need to do in order to look or appear the way that they need to be successful in the sport. For males, it could be injury or overtraining might be an important trigger. Sports that require or reward lower body weight, low body fat percentages, or a thin appearance have a higher prevalence. So gymnastics is a huge one, ballet, wrestling. Those are just a few quick examples. There you see more: bodybuilding, cheerleading, diving, figure skating, horse racing, jockeys. I mean, jockeys have to be little people. They're not tall, they're not heavy. They can't be. If they are, they're not going to be aerodynamic and they're going to weigh the horse down. So that's a sport where, believe it or not, a specific body type and then making sure that you keep those numbers correct for better performance of the horse are crucial. Rhythmic gymnastics. Running is another area where it can happen. Running, swimming, maybe even some cycling, ski jumping, wrestling, boxing, MMA. All sports that have a higher prevalence of disordered eating and eating disorders than other sports not listed here. There you see some ballerinas. Again, part of being a ballerina is being very petite. The appearance of the body is a very, very integral part of the art of ballet itself. So therefore you see that being a potential issue for those athletes. Look at this. I mean, swimmers, divers, they're not wearing a whole lot. So if they're showing off their bodies, they're going to want their bodies to meet specific image expectations, and so they're at risk. Now, on the other side, I know we talked about so many of these affecting women, but something that affects men more than women is sometimes known as the Adonis complex. I've heard it referred to as big orexia, and muscle dysmorphia is the name of it. It is a preoccupation with gaining muscle mass. It has some elements that are similar to eating disorders. Specifically, it has some elements that are very similar to anorexia nervosa, in the sense that with anorexia nervosa, there's no such thing as a minimum weight. Like they just want to get lower, lower, lower. Well, somebody with muscle dysmorphia that is looking in, they look in the mirror and they think that they're too small. No matter how big they are, they might look huge to you and I, but in their mind, with this warped sense of self that they have because it's a psychiatric condition, well, they see themselves as appearing too small and undersized, and so they want to be bigger and bigger and bigger, and they're going to take measures to get there. So here you see, you can pause this here. This might help you answer some of your questions that are coming up a little bit later. Karen, the cross-country runner. So this shows you what happened with her and how her story translates to this very specific pattern of transitioning from normal eating into her full-blown eating disorder at the end of the story. So you may want to go back, pause on that for a second, and go through it. Now, what's the difference? Okay, it's important to distinguish normal and dysfunctional eating. Remember some shared features here. High level of training, established eating plans, and body composition or weight goals, right? So if you're an athlete, you know that there's a lot of training. You know you have to have a good plan when it comes to your nutrition, and you know you probably need to make a certain weight or have a certain body type, body composition, etc. However, for normal behaviors, right, the good stuff, training is purposeful. In fact, it's supposed to make you improve. Food intake is monitored, but it's not strictly controlled. I mean, that's kind of how we started this discussion today. And your diet is planned, but there is some flexibility built into it. On the dysfunctional end of things, the training can become very excessive. The food intake is controlled. And when I say controlled, I mean very controlled. So much so that the diet becomes rigid and inflexible. And those are earmarks of disordered or dysfunctional eating as opposed to normal eating patterns for athletes. Remember, actions, perceptions, and outcomes are going to be very different. So in the case of normal versus dysfunctional, performance in a normal athlete should improve as the diet and the eating behaviors are going on, whereas if not, it will decline. Body image is accurate versus inaccurate. Muscle mass, is it maintained or is it decreased? Remember, as you restrict calorie intake, you're going to actually put your body possibly into starvation mode, and so you start losing muscle mass via gluconeogenesis, right? Your body will make glucose from other parts of the body that it needs to in order to get you the energy that you require. So it will steal it from your muscles. And then kilocalories, so your actual energy source, your fuel, sufficient versus insufficient. And a lot of times with athletes, the insufficient component is the important one to watch here. So all that being said, that's what happens. This is how it goes. What does that mean for you? How can you intervene? And guys, I got to tell you, this is not an easy situation. But I will tell you that if it's something you suspect, early intervention is critical. The longer these behaviors continue, the more troublesome they become, the harder they are to break, and the harder it is to actually help that person. Now, how much can you help? Well, that's an interesting question, because a lot of that is really outside of our personal scope of practice. You need to be a professional in the way that you approach it, and you have to maintain confidentiality. This is sensitive medical information that we're talking. What you really should do is approach the athlete and then refer them to a trained professional for evaluation. And if it's confirmed that this is what they have going on, they should be placed into a treatment program where they can get the proper coaching in terms of psychology, nutrition patterns, and other medical interventions. What's interesting in terms of personality characteristics of being a successful athlete versus someone with actual disordered eating, certain personality traits are the same. So perfectionists, people who are obsessive compulsive, people who are over compliant and really follow their orders, follow things direct, and being extremely competitive. A lot of times these are seen as positive personality traits, right? Ones that coaches want to see from their athletes, but if taken too far or applied improperly, those same kinds of personality traits could really lead someone on a harmful path when it comes to their health. And coaches should be aware of this, which many of them are not, unless, depending on what level they're at. But coaches should be very aware of this, because the things that they say and do might unknowingly contribute to someone going and developing disordered eating patterns or even a full-blown eating disorder. I'm not saying it's their fault entirely, but I'm saying that their influence, what they do, what they say, how they say it, it matters. It makes an impact. Here's a slide you can take a look at that looks at normal versus dysfunctional eating patterns. Again, looking at athletes here and their exercise patterns. Now we're going to get into something called the female athlete triad, which is marked by 3 very distinct things, and here's how they all interact with one another. You can go back to this, but let's talk about it. The female athlete triad means there are three things going on, and these are the three general characteristics. So first of all, there is disordered eating present. All right, because of the disordered eating, there is a low amount of energy being brought into the body, and therefore there's not much energy available. So that's the disordered eating. Amenorrhea will kick in, right, which is something that obviously can only happen to women. This is why it's the female athlete triad, and it leads to this is because of a sign of hormonal disruption. So if their hormones are disrupted because they can't maintain a certain body weight, and it's because of the low energy availability, well, then their menstrual cycle is going to cease. And when their menstrual cycle ceases, those hormones that aren't being released and regulated properly, well, they're going to have other effects on the body. And mostly, it's going to be something that happens actually and affects bone health, right? So there'll be lower bone mineral density in these female athletes, which can even lead to osteoporosis. So those are the three things: disordered eating, amenorrhea, and osteoporosis. Not to mention, because of the low energy availability and just not getting enough nutrition. I mean, it's not listed here, but in the case study we're talking about, Karen, she was sick a lot, and that's because her immune system is impacted too. So each of these conditions develops along a continuum. It's hard to determine. Any physically active female is at risk for this, but elite athletes who really have to keep themselves lean and have the highest amount of performance and they train the hardest, well, they're ones that might very well be at the greatest amount of risk. So the disordered folks that have disordered eating already are at the greatest psychological risk, right? They're the ones that are going to potentially move down this path further on this continuum to make the low energy availability component of the triad a little bit more significant. With amenorrhea, amenorrhea again is the absence or suppression of menstruation. When I say suppression, perhaps the menstrual cycle does come on, but maybe it comes on every other month or every 3 or 4 months, or when it does come on, it only is going on for a very short period of time. It's a pretty significant disruption is really what's happening. And again, it's because there's not enough energy availability and hormones get disrupted because of that. It's not due to low body fat stores or the stress of exercise. It has to do with the low energy availability and the hormones being disrupted. Amenorrhea that happens for longer than 6 months will likely affect bone mineral density. So when you think back to Karen, our case study that we learned about, listened about at the start of this particular chapter, she only had 2 menstrual cycles in an entire year, and she later went on and got a stress fracture. Does that seem like that may be related? I mean, perhaps. So there it is, the low bone mineral density and structural deterioration is usually a result of low estrogen concentration. Again, with that low energy availability, this is a result. So there's a greater risk for things like stress fractures, and thus early intervention is really important, because once you start affecting your bone health so significantly, I mean, it's only downhill. Because once menopause hits and there is no more menstrual cycle, we know already that women are more likely to develop osteoporosis and bone health issues later on in life. So doing damage early on like this really puts someone at a significant disadvantage long term as well. So you got to make sure that if this is something that you see, that intervention happens quickly and efficiently so this person can lead a normal, healthy, long life free of pain and dysfunction, or as much as you can possibly hope for. There you see what that low bone mineral density looks like. There should not be that much space in the bone tissue. Here you see a couple of a table here. The prevalence of female athlete triad components. People that have just one have all three. People that have just 2 of them: disordered eating and menstrual dysfunction, disordered eating and low bone mineral density, and people that have menstrual dysfunction and low bone mineral density. So they all work independently of one another, and you can see it in the elite athletes versus a control group. There is a pretty significant difference there in terms of what we're looking at. So this can happen in elite and recreational athletes. So the study that we're looking at here, 87 of 186 elite athletes and 65 of 145 subjects in the control group demonstrated at least 2 of the 3 or all 3 components of the female athlete triad. So of a random sampling of people, just even among elite athletes and the control group, it's pretty shocking. Shocking amount of people that actually suffer from this. This is a little bit newer. I haven't really seen a whole lot on this, but there's something called the REDS. The Red S is a proposed extension to the female athlete triad, and it's therefore a broader term than low energy availability, as they're saying that low energy availability can occur without an energy deficit. This can include males and females, and it negatively affects health and performance. Just bringing it up just so you know that there's other things going on that would certainly classify as being a part of this chapter, but early stages still. So what do? Prevention, intervention, treatment. If you see something, you notice that something's going on, I mean, the way that you approach someone is important. There's not a whole lot that you can do because you are not a psychiatrist or a psychologist, but establishing good rapport and staying close with that person is probably very important, because that's the thing with gyms. If you notice that someone is struggling and they're having a problem like this, and you confront them on it and you don't have good rapport or they take offense to it, even if your intention is to help that person, they're probably not willing and not likely to deal with it right away. So if you scare them away, right? So if let's say you're working at the gym and you say something to them and then they never come back to that gym, you didn't help that person, because now it's not like they're leaving that gym and then therefore they're going to stop those negative behaviors. No, they're going to continue those negative behaviors, and now they have no one that's going to notice and no one that's going to help them. So it's kind of a scary thought. No pressure. Screening is important, making sure people go to the doctor enough to make sure their menstrual function is intact. Doctors, and this is where doctors probably don't do it, but perhaps you doing some kind of nutrition questionnaire, asking about their eating habits and finding out about their lifestyle habits to make sure that they get enough food and see how much energy they're actually burning. You can do some laboratory tests for these sorts of things that they probably won't get called for unless there is a problem. So even though these can be listed as prevention, more than likely they're not getting done frequently enough to be preventative. But a DEXA scan to look at bone density, looking at blood counts, just look at hormone health. Those are some methods that exist. Some tables and things supporting that study that we talked about. Now, oh man, these are all just duplicate slides here. Sorry, guys. Coaches. Here's what coaches can do. Establish a culture that supports normal eating. Do not determine the athlete's weight or body composition goals, because again, people really listen to coaches. They will follow their word explicitly, and therefore it could be dangerous if it's not good for them. Don't suggest that body weight be reduced. I mean, I know for some sports I could see why you'd say, man, you need to, but if you suspect that someone is dealing with this, maybe these are some things to avoid. Let's look at it that way. Ideally, you send somebody to a registered dietitian, and preferably one that specializes in athletes and sports. This way they can determine appropriate weight and body composition goals. They can also figure out an appropriate caloric intake amount and the foods to do it. And you can make general suggestions, but a dietitian is the one to do it. Coaches don't cause eating disorders, but again, things that they say, things that they do, conditions that they create might actually encourage eating disorders to develop. So you got to be mindful of that. All right, here it is, the moment you've been waiting for. We're about right at 44 minutes in. You might want to freeze frame here, pause it. These are the 4 questions that will count as your lab. This is what tells me that you actually listened to this lecture and that you hopefully have learned something from it, and you paid attention to the story about Karen. Karen, who was the focus of the case study that I opened with. I read you the whole thing. Again, you can just sit and listen. I'm told that I have a nice reading voice, so hopefully you can understand that story. And just based on what we heard, and I even mentioned a couple things as I lectured on and we got into the facts that might answer these questions. So if you're just fast forwarding to the end here, that might not be helpful to you, but if you go back, listen to the story, or if you have the book and can read those pages, that case study that happens on the first page and a half, that will help you. So this is due not Tuesday, just because Tuesday we have a lot of things due, but it's due by the last day of class. Obviously, sooner the better. Email it to me in a Word document if you please. Answer these 4 questions. Guys, a quick summary here. Normal eating, it's flexible. Eating disorders are very serious. They are life-threatening. They are considered psychiatric conditions. Eating behavior has a continuum, right? Normal all the way to dysfunctional over time and in multiple directions, right? Overeating and all the undereating ones. It's best to know more about it and have education, finding some early identification, intervention, and treatment, because those are going to be the most beneficial. Coaches don't cause them, but coaches can help them along, which is unfortunate. And the female athlete triad, specific obviously to only women in sports, low energy availability, hormonal disruption leading to the cessation of their menstrual cycle, and low bone mineral density. This is a very serious medical condition, and it happens to a lot of female athletes, particularly those in the elite level. Thank you all for your time, for listening, for watching. Hope this wasn't too painful for you, and I will see you live in class soon.